Sir, please start. We are now online.
Yeah, thank you. Good evening to all. First of all, a warm welcome for Bayer Eyesight meeting. Today we have our speaker, Dr. Sriram Charan sir. Currently, sir is working as a vitreoretina specialist at Anand Eye Institute. With this, handing over the session to sir. Sir, over to you, sir.
Good evening, Andy. I'm Dr. Sriram Charan from Ananda Institute. So I thank Bayer for giving me this opportunity to present my case also, along with the interesting talk today. So today we are going to discuss about how the aflibercept in a treat and extend regimen helps us balance the efficacy with the treatment burden in AMD. So this is increasingly relevant because in the real world practice, it's going to be very interesting. So this presentation is based on published trials and real world evidence. So what are the unmet needs? So despite advances in neovascular AMD management, still there is a major challenge, that is the treatment burden. So frequent injections will cause may result in poor compliance from the patient side, and that is more important because it will result in under treatment. So the Euretina survey also, it shows that 70% of clinicians feel that injection frequency is the biggest unmet need. So if this is published one is only 70%, in real life, the outcomes are even more worse than the trials because of the under treatment. So what is the ideal anti-VEGF injection we need? So we should the ideally we require less number of injection, and we need a longer durability and less or practically no complications. So this ideal anti-VEGF we'll see in following slides whether our aflibercept will satisfy it. So here VEGF suppression variability. So the aflibercept suppresses VEGF for 70 days on average. So this varies widely among the patients. So in some patients in real world, we may see that it might last even longer. So this variability forms the basis for the individualized therapy. So fixed dosing will ignore this biology. That is, the duration of VEGF-A suppression with aflibercept varies up to 16 weeks. So this number of 16 weeks is what very important. To achieve this Q16 is the major goal of any anti-VEGF agent. What is Q16? That is duration between each injection. If we can extend it up to 16 weeks and more, then practically we might be achieving the ideal anti-VEGF agent required for NAMD treatment. So what is treat and extend protocol? So here it is a proactive strategy where first we give 3 loading doses, then we extend the interval of follow-up gradually. So and inject at every visit, no observation phase. So extend if stable, shorten if recurrence. What is that we are extending and what is that we are shortening? Here we are extending the follow-up period and shortening the follow-up period depending on the OCT. What we see here are the OCT changes. So after the 3 monthly dose injections, we wait for 4 weeks. Then we see for a repeat OCT and visual acuity. If there is fluid and if there is a drop in visual acuity, then we will shorten the interval of follow-up. If there is no fluid and there is no change in the visual acuity or stabilizing of the visual acuity, we extend the follow-up. So finally, our goal is to identify each patient's maximum disease-free interval. So what is the durability of the current anti-VEGF agents we have? So this is a slide which is showing the ranibizumab, which is requiring more frequent number of injections. And if you see to the corresponding visual acuity gains, there are number of injections are more. So about 18 injections in TREX trial. In CANTREAT, they have also seen that the patient is requiring 17 injections. So on an average, more than 15 injections from the point of diagnosis to the end point, that is the 2 years of the treatment. Whereas in brolucizumab, this is a promising one. But here if we see, the brolucizumab also only 40 to 45% are maintaining the Q12 only, not even up to Q16. So, and also we can see that there is an amount of IOI risk of IOI in brolucizumab, that is the intraocular inflammations. So here the another promising new drug, which is the faricimab. So this is 6 mg faricimab. It is promising but has practical limitations. If this is introduced in the market with a idea of reducing the reducing the number of injections, but irony is about 25% are requiring 4 injections. That is the loading dose as well. Apart from loading dose, another injection is required in faricimab. So this also is not exactly fitting into the our anti-VEGF, ideal anti-VEGF situation. So then here that's what I'm trying to tell you. When compared to faricimab, the aflibercept, so they have prevented the direct comparison, but here if you can see, almost they are receiving 4 injections for faricimab when compared to aflibercept 2 mg, which is only 3 injections. So now if we see, come to the point of why aflibercept, because aflibercept, it is having a strong binding affinity to VEGF and PIGF. So this contributes to the longer duration of action. So here it is offering both efficacy and also durability. So what is Altair study? So the Altair study is the key study which evaluates the treat and extend regimen in aflibercept. So here if we compare the aflibercept 2 mg by extending the treatment interval between two groups, that is in one group we are observing for 2 weeks and in the other group we are observing for 4 weeks. So the primary endpoint is at 1 year and the end of the treatment is at 2 years. So let us see which one, in each of the two groups, which one is faring better. So here this explains the maximum interval of Q16. Are we achieving that or not? So what is the criteria here in this study? We extend the follow-up when there is no fluid present, as I told you before, and when there is no change in the visual acuity. We maintain the follow-up phase of every 2 weeks, where when there is a residual but decrease in the fluid, and there is no loss of the visual acuity. That is, there is no decrease in the visual acuity, and we shorten the follow-up period where the fluid is present. If the fluid is present and if the visual acuity is also coming down, then we will have to shorten the follow-up phase and we will have to inject. So here if we see in this study, visual gain is maintained between anywhere between 6 to 7 letters, and the 40 to 46% have reached the Q16, what we have earlier described it as an ideal way to observe the durability of the anti-VEGF agent. So that is, and here importantly, there is no compromise in the vision as well. So that 6 or 7 letters gain, which we are achieving at first 3 injections, it is being maintained for longer period. That proves that the aflibercept is more durable. So then how is the injection burden here? So here about 10 injections over 2 years is the average. So year 2 is requiring less than 4 injections. So in first 1 year itself, the major portion of the injection requirement is there and that vision gain is stable up to the end of 2 years also. So durability as well. So 60% patients are maintaining more than 12-week interval, which shows the major benefit from extension. So once the extended to 16 weeks, that is Q16, almost 96% are remaining stable, at least not deteriorating in their whatever vision they have. So now coming to the question, whether if it can, the RCTs what we have seen till now, are they really produced, translated into clinical practice? So here I would like to present my case where a 65-year-old female, she presented with a diminution of vision in left eye. Her presenting visual acuity was 636 on examination. So the fundus showed a tall peaking PED with a minimal, with a double layer sign, and also the lumpy bumpy RPE, if we see here, lumpy bumpy RPE, and with fluid besides the PED. Though all these four features are suggestive of we are dealing with a PCV, that is polypoidal choroidal vasculopathy. So here what I have done is we have started aflibercept loading dose. So she received 3 monthly injections. So the patient presented to me on June 2022. So June, July, August, 3 months she received loading dose. Following up with follow-up period for here we have followed up for with 4 weekly, that is the treat and extend regimen with every 4 weeks. So I extended the follow-up every 4 weeks. So after the 3 monthly injections, we can see here there is a the PED is almost collapsed, and the fluid which is persisting there is a minimal fluid that we can just be kept for observation. And on if we can see this one, almost this OCT I have taken after 2 years, that is in March 2026. Here if we can see there is a slightly elevation in the PED, but more or less it is stable, and the fluid also is not there. So here the total injections in our case is she received is only 7 injections. So, and dramatically our visual acuity also improved to 6/12. So RCT-like outcomes are definitely achievable in real life. So 35% achieved this Q16 interval. So this is crucial because trials don't reflect the compliance issues. But here in real world, what we have seen, the patient has definitely benefited with the aflibercept. So the practical treat and extend regimen here. So we extend the follow-up when there is no fluid and when there is stable visual acuity. And as I have told before, almost 60% of the eyes were being treated at an interval of 3 months. So here what is to be noted is that the lower logMAR values equate to better visual functions. And there is, see, not all the fluid needs aggressive treatment. So as in my case, if we have noticed that small amount of IRF which was there, we can just observe it. So when to treat? Whenever there is a fresh PED and whenever there is a fresh episode of something like a bleed or any submacular hemorrhage or anything, when we have noticed that sudden drop in visual acuity, that is the time when the OCT is showing more fluid, that is the time we'll have to treat. But minimal fluid we can observe as well. So sustained visual outcomes, reduced injection burden, and personalized treatment. So all these three are very, very important goals which we can achieve with this ideal anti-VEGF agent, that is aflibercept. So ultimately what we have seen and what in our case also we have observed the similar result. So the majority of the studies also are saying the same, that is the Q16 is achieved. So of the all anti-VEGF agents, aflibercept binds with the most diverse range of VEGF-R ligand, and this is a key driver for retinal disease. As supported by wealth of data, aflibercept 2 mg has been shown to deliver. So there is improved long-term outcomes with regular or proactive treatment. So the aflibercept treat and extend regimen offers flexibility to achieve and maintain the vision gains with intervals of Q4 and to Q16 while tolerating some residual fluid and reducing the treatment burden. Thank you.
Thank you, sir. Sir, we will wait
I
another
hope I
10
was
minutes.
clear with my presentation.
Yes, sir. Perfect, sir. Perfect. We will wait another 1-2 minutes, sir, so that if
Okay.
any queries, we will
Sure.
clarify, then we will close.
Sure. For long-term treatment, elaborate treat and extend and PRN. Madam, actually treat and extend regimen is more, it actually balances both the treatment schedule as well as the burden for the financial burden for the patient. That is the most important difference between TND and PRN. PRN is, as we know, as and when the patient comes, whenever we see the fluid, we just inject. But in PRN, the problem is there will be loss of follow-up. We do not know when the patient has received which injection, and the proper record will be missing in PRN. And nowadays we see many of the patients, they don't turn up. Once they see that wow effect, they generally won't turn up. Whereas in treat and extend regimen, what we do is we proactively call the patient every 2 weeks or every 4 weeks after the loading dose of injection, and we observe the clinical change as well as the OCT markers. So of course, I am not saying that we do OCT at every visit, but once the loading dose of 3 injections are given, generally after 4 weeks, we see the patient again. That is after four, and from there we call them for another 12 weeks. So at that point of time, if the patient is maintaining the visual acuity, then we just observe the patient. If there is a change, as I have told you previously, clinically, if we see any fresh PED or any fresh submacular hemorrhage or any new changes in the retina, then we advise an OCT. And if the OCT is, we observe, we nowadays the machines have come, such a nice machines. They themselves will compare the OCTs of previous visits and give us the data whether there is a activity or not. In treat and extend regimen, it will be more controlled. The control will be more with ourselves as clinicians. Whereas PRN, it's a very vague way of treatment, because we do not know whether the patient has responded or not, and we do not know whether the agent also is, did he take the same agent? Maybe previously he might have taken some other anti-VEGF, and now to decide on whether to change the anti-VEGF agent also, it will be very difficult in PRN regimens when compared to treat and extend regimen.